It really is a pleasure to be here today. I appreciate everybody coming out. I know it's a little bit less cold than it was in Cleveland a week ago, but it is still not what I would describe as tropical. So I appreciate everybody bundling up and making the trek to come to today's talk. We are recording, and I'm going to be going through some slides, but I also am of the opinion that to have interaction with our audience and with our community, which is really the essence and soul of the PRC, is the way we all learn collectively. So what I am going to encourage you to do is, if you have questions, if you have comments, please feel free to just raise your hand, and we'll do that while we're going through the slides. So I think that'll make it more interesting. I am deeply appreciative of the opportunity to conduct this research. This would definitely not be possible if I was not here at CASE and affiliated with the PRC. As Sue mentioned, this is kind of a limited competition for grant funding, and this really was the way to make this happen. I believe this is the perfect setting for this type of research. What I'm going to be talking about today is the role of self-management in managing epilepsy and reducing complications. This is a variation of a talk I did last summer to a group called PAME, Partners Against Mortality in Epilepsy. It's a wonderful, wonderful meeting to those of you who have not been there. And what's really unique about it is it involves scientists, researchers, and also families who've lost loved ones to epilepsy. And so it's really a profoundly moving meeting. Everybody's really invested in doing what we can to make sure that in the future people with epilepsy do the best they possibly can and have the fewest complications. So that's really our shared goal. Yeah. Okay, so just to give you a little bit of background and introduction, maybe before I get started, I'm going to do a little head count here. How many of you know someone or have epilepsy, someone who has epilepsy or have epilepsy themselves? Somebody has sort of personal experience. All right, it looks to me like it's probably 2/3 of our audience. Not surprising. I suspect that's kind of what drove you to be here. How many don't have epilepsy or don't know anybody personally? Okay, so 1/3 of our audience. So, this is not necessarily representative of the general population, but it's how we learn. It's how we learn together what epilepsy is and what epilepsy is not. Epilepsy is a neurological disorder characterized by recurrent or unprovoked seizures. The unprovoked is the particularly critical part here, is people who have epilepsy very often never know when a seizure is going to happen. Imagine living your life if something kind of catastrophic, dramatic was going to happen to you, but you never knew when it was going to happen. Have you ever been expecting a phone call, right? Like you had a meeting or an appointment, you were expecting a phone call? I'm sure. I see heads. All right, so you can't really do anything before that phone call, right? Because you're expecting the phone call, so you don't want to go start eating your meal or whatever because you're waiting for that phone call. Now imagine if you're waiting your whole life. So that is the kind of big deal with epilepsy, is that sort of unprovoked, unpredictable, how can you plan your life to the best that you can, knowing that something can happen at any time. In addition to that unpredictability, the all-cause risk of death is 3 times higher in people with epilepsy than in the general population. So we know mortality is elevated. That's why a group like the PAME group exists. The other thing that the research literature tells us is that rates of serious mental illness, such as schizophrenia, bipolar disorder, and severe and recurrent depression, are also disproportionately high in people who have epilepsy. So if that's not bad enough, bullet point number 4 is really important, is that epilepsy and psychiatric illness are both heavily stigmatized in our society. It wasn't very long ago that it was uniformly and widely believed that people who have epilepsy are possessed by demons, and when they would have a seizure, that was clearly some manifestation of that. So if you think somebody is possessed by demons, what's your natural reaction when you're around that person? like no longer be around that person, right? Right? Because the demon might come into you. I mean, who knows what's going to happen? So for the most part, our society has moved beyond that, but there's still a lot of stigma, and in many cases, the stigma has gone underground. Psychiatric illnesses, things like depression, are also highly stigmatized, you know, and I believe that that's still, unfortunately, alive and well. So if you have both epilepsy and depression, we think about that as double stigma. Suicide rates in epilepsy, in people who have epilepsy, are 5 times the general population. And let me talk some of the ideas about that. So to dig a little further into the potential epilepsy complications, there's something called sudden unexpected death in epilepsy, or SUDEP. And this is a biological event where people suddenly have a cardiorespiratory arrest. They die suddenly in the midst of having kind of repeated uncontrolled seizures. 5% of deaths in epilepsy are related to SUDEP. Even higher are the rates of suicide, 1 to 17%. Suicide data is a little tricky, given the stigma related to suicide. Sometimes you can have somebody who dies where it's not necessarily recognized as a suicide. For folks who don't have those mortality complications, we know that seizures can cause injury. You can fall, you can hit your head on something, you can get a fracture, and 30% of people who have epilepsy experience a seizure-related injury. We do know, the good news here is that some complications are preventable with self-management. So, for instance, poor medication adherence, maybe missing some of your regular doses of medication. And one of the tricky things about anti-epileptic drugs is they need to be taken regularly. You know, you can't take a drug holiday. You have to take them in particular windows of time. Poor medication adherence is associated with elevated risk of mortality and with complications. Poor adherence increases the fractures related to injuries and accidents, emergency department visits, and hospitalization. So, you know, what's sort of driving this is the better a person can learn to self-manage their epilepsy, the less likely they are to have some of these bad complications. And medication adherence is one of the foci, not the total. So I want to dwell a little bit on the mental disorders being common, because that's part of our work. We know that having a mental condition on top of epilepsy almost always worsens the outcome. 20 to 70% of people with epilepsy meet criteria for psychiatric disorder at some point. The risk for psychosis, conditions like psychosis with depression or schizophrenia, are 6 to 12 times higher than the general population. And what's interesting is there's sort of this bidirectional relationship, you know. Some people automatically assume that the reason people with epilepsy are more likely to have mental disorders is because of the challenges and the stigma and the stress of living with epilepsy. But our research suggests that that may not be entirely the whole answer. So we know that people who have bipolar disorder and depression are at increased risk of later developing epilepsy. And so they kind of related to each other. People who have a history of a suicide attempt are also at later risk for developing epilepsy. And people with epilepsy and depression have a cumulatively higher risk of mortality. So this I think is an interesting point. So in contrast to the previous belief that psychiatric symptoms are because of stress due to epilepsy, and I won't minimize that because I believe that's true as well, emerging research suggests that there's a bidirectional relationship. And psychiatric disorders may actually lower seizure threshold, which means it's more likely that a person will have a seizure. Right? And it is possible that the same types of things that cause epilepsy are the types of things that can cause psychiatric disorders, vice versa. So this is really an interesting area of research. I think it definitely needs to be pursued. And some of our sort of intuitive understandings of the relationship between mental illness and epilepsy, I think, need to be updated. So let's shift gears a little bit and talk about epilepsy self-management. That's really our focus. You know, we can sit around and talk about complications and stigma and premature mortality and all that stuff, and, you know, it's true. But I think it's more important to think about what we can do to try to minimize those complications. And epilepsy self-management is known to reduce complications. What is epilepsy self-management? So Dr. Diorio, one of the really major researchers in this area, has described it very nicely in one of her publications. Broadly speaking, epilepsy self-management is the sum total of steps taken and processes used by a person to control seizures and manage the effects of a seizure disorder. So it's really everything that the person does, everything you do. It's not just taking medicines, not just going to. There are a variety of different domains that people can address with epilepsy self-management. Medication is certainly one of them, being adherent, managing refills, getting the AED, stands for anti-epileptic drug levels, routinely tested. Seizure management, so there's something that we call seizure triggers, the thing that makes it more likely that a person will have a seizure. Some people have clear seizure triggers, other people do not. Managing the seizure consequences, disclosure and stigma, how's a person going to deal with that? Lifestyle management, so stress reduction is important in reducing the frequency of seizures. Managing limitations with driving, traveling, employment, shopping, recreation, pregnancy. So in the state of Ohio, there are pretty significant restrictions on driving. You know, basically somebody who's had recent seizures and known epilepsy is denied a driving license. So, you know, here in Cleveland, we're probably better than a lot of the states, but we still have a terrible public transportation system. Imagine if you are not able to drive, the kind of limitations on your lifestyle that would happen. There are other types of healthy behaviors. We know sleep and wake cycles are important in making epilepsy as least complicated as possible. And those are the kinds of things that people can learn to make. Oh, that slide didn't come out good in this light, I guess, huh? If we can get the top one, let me just sort of take you through this. This is another slide that has been presented in previous lectures or talks shown by the Managing Epilepsy Well Network, which is a group that I'm part of. We know that people with epilepsy, like all of us, live in complex worlds. So the management of kind of all of these different components of life is affected by a variety of things. Finances, healthcare providers, health and illness, people's social environment, their physical environment, and all of those things make up what a person has to deal with as they think about dealing with health conditions. There are a variety of barriers to epilepsy self-management. Forgetting to take medication is very common, especially if you have to take more than one medication, especially if you have to take the medication more than once a day. How many of you have ever been prescribed a 8 or 10 or 12 day course of antibiotics? How many? All right, almost everybody. How many of you have taken that entire course of antibiotics, every single pill at the time you're supposed to take it? One. You notice I did not raise my hand. I definitely. She should be up here, right? But, you know, that's life. It is very hard to remember that. Sometimes a lack of understanding of the treatment goals can be problematic. So, for instance, the difference between prophylactic and symptomatic treatment. When you have a headache, you take a pain reliever, a Tylenol, it goes away. But if you have epilepsy, even if you're doing well, even if you've been doing well for years and years, you have to keep taking that medicine. So it has a prophylactic effect to prevent the occurrence of future seizures. So that's very difficult, and there's not a concrete reminder. Suboptimal medication efficacy. Unfortunately, while our AEDs, our drugs for epilepsy, are pretty good, they're not perfect. And there are a lot of people who, religiously take their medicines, and it still does not work to totally stop seizures. Medications have side effects. All medications have side effects. But AED medications tend to have a lot of side effects, so things like being sedated, cognitive dulling, where you're having a hard time focusing, weight gain, sexual dysfunction, a lot of side effects. Depression and other psychiatric symptoms, we already talked about how common that is. So if you're depressed, it's very hard to get engaged to do all of the things you need to do to self-manage your epilepsy. Stigma. If you're a student and you're in school and you're supposed to take medication 2 to 3 times a day, and you're with your friends, let's say you're on a field trip somewhere, The last thing you want to do is say, no, hold it, I got to go take my medicine here. You know, you don't want people to know that you're being treated for epilepsy. Lack of social supports, probably having to do with the stigma, and also lack of access to care and medication. So care can be expensive, care can be difficult to access reliably. Some of the AED medications, particularly those that are not available in generic formulations, are incredibly expensive. And that can be very, very difficult depending on the personal circumstances. So if we think about the self-management continuum, knowing that behaviors to manage health are important to quality of life, there are ways of coping with things that happen in life that we all encounter. So proactive behaviors might be the things that are associated with positive quality of life things. You know, sometimes we can cope with stress in positive ways, sometimes not such positive ways, right? So for instance, using alcohol or drugs might be a short-term fix, but long-term, not so good. And so let me bring up the group that I've been really fortunate to be involved in for the last few years now, called the Managing Epilepsy Well Network. As Sue mentioned earlier, this is part of the PRC network. These were funded by the SIP mechanism. Started with funding in 2007 of 2 sites, and that has grown to the most recent funding cycle in 2014 with 8 sites. And you can see where these sites are located, scattered around the United States. The mission of the Managing Epilepsy Well Network, we call this the MU network, is to advance the science related to epilepsy self-management by facilitating and implementing research, conducting research in collaboration with network and community stakeholders, and broadly disseminating the finding of research. So what can we do to improve public health? What can we do to improve the lives of people with epilepsy? So that's really the main focus. There is a website there for some of you that might be interested to read more about this. And now I want to shift gears again and talk about some of what our group has been doing. So as I said, we've been very, very fortunate to be part of the MU network now. This will be going into our 3rd year. And our focus is changing health outcomes using a behavioral approach. When we think about lifestyle or behavioral approaches to improve health, we have to consider a number of things. First of all, what works? So, you know, what does sort of scientific methods tell us works? What does not work? What is practical? You know, so you can have the most scientifically kind of cool thing. Did I just lose my? Yeah. I knew we were going to have this problem. Yeah. Okay, hopefully that'll continue us. What's practical? So you can have the most whiz-bang, scientifically rigorous research study, but if it's not practical for use in the real world, then it is unlikely that people with the health condition are going to actually benefit. It's not going to be disseminated widely. So, you know, elitist science that doesn't help the person with the health condition is not reasonable for us to spend our time on. So we're really focusing on what's practical, what's acceptable to patients, what's acceptable to families, what can be sustained in typical community or health practice setting. The self-management network, so the MU network, has developed a few evidence-based approaches, including projects called PEARLS, Uplift, and WebEase. I won't go into all the details on those because our time is sort of limited today, but the group has conducted some really high-quality research in this area. There was a publication on the PEARLS study in epilepsy behavior that was funded with a federal. And this is an example from the PEARLS study of some of the outcomes of interest. So looking at depression, for instance, as we mentioned, depression being such a significant problem in folks with epilepsy. So this is a comparison of people that were in usual care here in blue, usual care in red, and looking at depression scores over time. And then we had our PEARLS group here in blue, and you see that over time, the folks who were in the experimental intervention had improvements in depression compared to the usual care. And similar, looking at what's called suicidal ideation, thoughts of death or thoughts of suicide, which are not uncommon in depression. And those also improved with the PEARLS intervention. So those are the kinds of outcomes that the MU network projects might be interested in. The MU network is also heavily involved in work with community and advocacy organizations. So the National Epilepsy Foundation participates in communication efforts. This is a national group. They have a very good website. They do a lot of very important advocacy and education and dissemination. The local Epilepsy Foundation affiliates are involved in program development, in MU and Epilepsy Foundation webinars. They've disseminated the PEARLS training nationally. When we are doing our projects here, we involve our local version of Epilepsy Foundation, which is Epilepsy Association. So they're part of our team of investigators and help us make sure that when we refine interventions, that they're, again, like I said on those bullet points, that they work, that they're practical, that they're acceptable. In our last funding cycle, there were a number of projects under development, and you can see the names of them here. We all come up with a little kind of acronym and a little logo for our studies. Our CASE acronym was the TIME study, Targeted Illness Management in Epilepsy. And our focus in this last funding cycle, and that should be adults with epilepsy, sorry about it, I don't know what happened to my A there, is that we focus on people who have comorbid serious mental illness. So the schizophrenia, the bipolar disorder, more recurrent or more severe depression, which has not, up until this point, really been historically a focus of the MU network. And we really wanted to focus on that population because they really are historically marginalized and disadvantaged, and as I mentioned, often experience this double stigma. Our logo, the TIME. We had a competition to come up with the logo, and I have some very good people to help me with graphics. I'm terrible with graphics. All right, we did a two-phase study. We are still in the process of collecting data, but we're getting close in completion. Two-phase study, as I mentioned, our population is people with epilepsy and serious mental illness. I use the acronym SMI here. First phase. Phase 1 was refine a behavioral intervention to enhance self-management. So I have been doing work in self-management and health promotion for about 15 years now, and we have some protocols that we've used for other health conditions. So our idea was we were going to adapt this for folks who have epilepsy. And then phase 2 is a comparative trial of time. In addition, CASE has taken a leadership role in developing an integrated MU network database that will pool data from completed and new studies. And this is, I think, a very exciting focus that I hope we'll be able to continue to a greater future. This is a graphic of the project, so phase 1, which is completed. So what we did is we convened a community advisory board and developed a group-based psychosocial intervention to meet the specific needs of people with epilepsy and serious mental illness. So we were very, very fortunate that we were able to get people from the wider community to help us. And then phase 2, which we're coming down the home stretch and getting finished, is we enrolled people with epilepsy and serious mental illness. So our target is 44 enrolled. And then they were randomized on a one-to-one basis to our time intervention versus treatment as usual. And then, as you can see here, we would assess outcomes. So it was a prospective intervention. So phase 1, as I mentioned, actually that slide. Our inclusion-exclusion criteria for our study, for our phase 2 study, is that we would enroll people who have able to provide written informed consent. For this initial trial, we confined it to people who could speak and understand English. We do have staff who are fluent in Spanish who can assist folks who are bilingual English-Spanish speakers. 18 and older, diagnosed with epilepsy, and then according to DSM-4 criteria, having either schizophrenia, schizoaffective disorder, bipolar disorder, or chronic or recurrent depression. And then we were looking for people that were using some type of publicly funded care, whether it's a community mental health clinic or some type of similar situation. We did exclude people who were actively suicidal or homicidal. If we had somebody that we screened who was actively suicidal, that person could be rescreened once they were no longer in that acute situation. I said we want this to really be real world, we did exclude individuals with dementia. And because their self-management needs could be considerably different, again, for this initial trial, we did exclude pregnant women. Okay. Primary outcomes of interest are changes in depressive symptoms as measured by a standardized depression rating scale called the Montgomery-Åsberg Depression Rating Scale, or MADRS. Our secondary outcome were epilepsy control, and we measured that by how frequent seizures occurred, medication adherence, the use of substances, non-prescribed substances, global or psychiatric overall severity, stigma levels, sleep, and quality of life. So measures that we think are relevant to how people experience and how people manage their epilepsy. A couple of innovative things about our project. We use peer educators to run our program. So our group interventions follow a curriculum, and the group is run by a nurse as well as an individual who has experience with the health condition. Unlike going to routine medical centers where you go in and you talk to a clinician or a doctor or somebody who says, you know, you do this and you do that, you know, how many of us really like being told what to do? I don't like being told what to do. But if you're talking with somebody and interacting with somebody who's walked the walk, that kind of information could be much more useful. So we think that's innovative. We also are leveraging the expertise and network relationship from the case PRC. Dr. Borowski, who's sitting in the back there, and other folks with the PRC have been so enormously helpful in helping us to make the contacts and connections with the community. So you guys are a beautiful representation of that, you know, really getting help from where this intervention needs to be and what it needs to look like. We are also, as I mentioned, doing this work with the integrated database, and we have some assistance from some informatics experts here at CASE that's helping us to move forward. So that's another innovative part of our program. Now, where do we get this idea? As I mentioned, I've been doing this self-management for a while. And what I'd like to tell you about quickly here is a self-management prototype that we developed for people with mental illness and comorbid diabetes. So if you look at people who have serious mental illness, what you see is that they have very high rates of medical conditions for cardiovascular risk and for diabetes. So obesity, smoking, hypertension, dyslipidemia, all of those rates are much higher than in the general population. And as a matter of fact, independent of epilepsy, people who have serious mental illness, on average, die about, I'm having trouble with this mic, on average die almost 20 years sooner than the general population. So the rates of premature mortality are just, you know, through the roof. The green light's on. Okay, sorry. You're recording. All right. Why does that happen? Why are those rates of cardiovascular risk so high? And this is relevant to epilepsy as well because there's a lot of similarities. So indirect or direct behaviors. If you're stigmatized, you become socially isolated. Then you're inactive. Then you're taking medication that worsens the effects of inactivity and side effects. Poor diet. You know, if you're not able to go out easily and live in a neighborhood where you can get fresh and healthy foodstuffs, PRC knows all about that. That's not the greatest thing for you to put in your body. Rates of cigarette smoking are higher. Rates of drug use are higher. And then you get the cognitive effects from having the mental illness itself. We know people with epilepsy can have cognitive effects as well from both their seizures or from the medications that they're taking to control the seizures. So our study, our diabetes SMI study, looked at both of these things and addressing both the facilitators and barriers to self-management. And then we looked at types of health outcomes. Our approach is based on a social cognitive theory, and the belief is that people learn by observing others, both good and bad. I think we learn just as much from our mistakes as we do from our successes, at least I do. Effective modeling teaches general rules. We believe that self-efficacy is important. That's an individual's ability to problem solve. And we also put a lot of faith in something called outcome expectancy, and this is a concept that's been tested in a variety of research studies. but it's a belief that a given behavior will result in a specific outcome. So if I believe that going on a weight-reducing diet will in fact reduce weight, I'm more likely to adhere to that. I have to believe that it's going to have the effect that I'm looking for. And so the premise is that knowledge, self-efficacy, and outcome expectancy are all precursors to behavioral change. What I really would like to point out to here is it's not just knowledge. So just giving somebody information, telling them, if you smoke cigarettes, that's bad for you. If that was all that was needed to reduce smoking rates, then probably none of us would be here. But you need more than knowledge. So our TTIM methods is we run 12 in-person weekly group sessions. There's a standardized curriculum that's semi-scripted. It's delivered by a nurse educator who has experience in the health condition and a peer educator who's walked the walk. Not the person who's perfect, all right? We just want somebody who has experience with the condition. We focus on active self-management. As I mentioned, it's manualized. That peer educator component is the secret sauce, in my opinion. It's really important. You've got to have that component. We got funding from the National Institute of Mental Health, NIMH, to run a large-scale randomized control trial. I'm happy to say we've completed this trial. We've completed an enrollment. We're collecting our final data now. It was a 5-year study. And this might be a little hard to see, but in our primary outcomes, looking at change over time, so we had our experimental group here, our TTIM group here, and then we had our treatment as usual here. And when we looked at our 30-week outcomes, so 6 months more or less, we look at MADRS scores, so depression scores. The teams, they started off 24 and 25. Those are the experimental versus the controls. And then 6 months later, our TTIM guys are down to about 15, Tau 21. So we had a significant difference in treatment. We believe we have an intervention works. Not all the outcomes were changed. We didn't expect them all to change, but the ones that we hypothesized being changed were changed and improved in the expected direction. All right, so let me get back to time. So we have this prototype that we're modeling the time intervention on. As I mentioned, we had phase 1, where we convened a community advisory board. We had a series of 3 meetings that went out over a period of months. Our CAB members numbered 11. You can see some of the demographics there. We had 5 community health professionals, 4 people with a health condition. We had care partners who believes that families, friends, the social environment's important. In our phase 1, we did a kind of full-scale qualitative analysis. So in these CAB meetings, we audio record everything, and then we transcribe it. And then we put this through qualitative analysis using some software packages to help us. And we identified certain things that are barriers to epilepsy self-management and kind of SMI self-management at the individual level, the community level, and at the health system level. For self-management, we're focusing on things that the person themselves can control. Okay. So let me just give you an example. For instance, let's say a medicine is too expensive. All right. Doctor prescribes something that's too expensive. Our intervention is not about writing to Congress to change drug prices, okay? I think Congress has other things on their plate right now. But if a person is prescribed something that they cannot afford, what are the other things they can do? How can they go talk to their health professional about getting on something different, potentially? Is that something they can explore? So we teach people how to communicate with their care providers. Are there other sources or other ways that they can get their needs met that are controllable or modifiable for them? So we were attentive to those barriers that were identified. We also identified what are the facilitators, what are the things that the person can do that can help themselves. And those we wanted to make sure that we incorporated into our intervention. So things like stress management, learning about medications, generic versus brand names. So there were people in our group who had gotten in trouble because they got 2 prescriptions that looked like they were 2 different drugs, but actually they were the same drug, and one was labeled with a generic name and one was labeled with a trade name. And those names were absolutely different. There's like no way you'd know they were 2, unless you knew to look for that. So our summary from the CAB was that people who had low trust in providers, those who experience frustration, stigma, and low social support may be less likely to effectively self-manage. So how can we improve those things? And then in terms of facilitators, empowerment, support from peers, providers, and the community are instrumental in helping people with EMI, so the epilepsy and mental illness, follow through with health recommendations. So what can people do to marshal things in their environment that can help them cope more effectively? Then we launched into the phase 2, our comparative study design, and this graphic shows what happens in our time intervention. So people are enrolled, we do a baseline assessment, then they're randomized to either our time arm or treatment as usual. Now if they're in treatment as usual, they continue to see their providers and continue to do what they're supposed to do, but they don't get anything else. If they're on our time intervention, they get these 12 weekly groups run by the nurse, run by the peer educator, and then there's a period of telephone follow-up, which is, I think, just a month for this study, and then we assess them at 4 months. So we're prospective, 4-month comparative design. Any questions about that? The graphic is a little bit busy. All right. Just like the TTIM intervention, our time has some similar theoretical underpinnings. So we believe that we need to give people education, but we also need to help them to learn how to solve problems, and not a specific problems. This is under the idea of, if a man's hungry and you give him a fish, that doesn't help. You need to teach him how to fish. So that's what we're really about, is teaching people how to fish in terms of self-management of these conditions. There are some targeted constructs we have, both the social support of the intervention as well as learning how to gain social support. So the way that I kind of conceptualize this is we all make health decisions every single day, multiple times, all of us. All of us. I'm standing in the building and I have to decide whether I'm going to walk up one flight of stairs or I'm going to take the elevator. Am I going to take my gloves with me when I go out to my car, or am I not going to bother fishing out my gloves? So we all make those decisions. And if you can get somebody to have a positive emotional feeling about a health decision, that positive emotion will carry through. That's what we'd like to see, that will stick with them. So even though I'm not in my group anymore, or I don't have somebody talking to me, I sort of still feel that person when I'm making those health decisions. And that's what our motivation is. We believe that those constructs will translate into health practices, and then further downstream translate into improved health outcomes. Sorry. Here we are. Act on the best solutions. So it's identify the problem, that's the I, define the possible solutions, evaluate the solutions, and act on the best solutions. All right, the idea approach. And we take people through different examples, and people are encouraged to bring their own examples in and do some group problem solving. So we have 12 sessions. We always do a graduation at the end. These are wonderful. I have a couple of my research staff, Carrie Zimmerman and Jamie Van Dorn, who are in the audience here, and I think you will vouch that the graduation ceremonies they're really inspiring. People really, really value being able to get the curriculum and support each other. All right, so what are we doing with our effects? At this point, we've had 2 cohorts who've completed the time versus tau intervention. So we're about 2/3 of the way in having the data that's analyzable. As you can see, looking at our sample, mean age 47.7. We have a preponderance of women in our interventions, and that's been true of all of the interventions that we've been doing so far, except for one with Parkinson's, where Parkinson's is more likely to occur in men than in women. But on average, about 70% of our samples tend to be women. I'd like to try and oversample more for the men. It's harder to get the men to come to a group, but we're going to keep trying. Almost 52% African American. I think this is telling. Look at employment rates, and this is really not surprising in epilepsy. So under 7.5% employed. And that's really, this kind of sometimes devastating effects of epilepsy. Psychiatric conditions, schizophrenia, almost 15%, bipolar disorder, a little over 40%, and depression, 26%. In terms of our data, so we don't have, we're underpowered yet because we haven't achieved our total, analyzable data yet. But if we look at the data that we have, our mean baseline MADRS, 17.1 for our intervention arm, down to 12.6. So we, again, even with a small sample, are seeing an improvement trend going in line with the TTIM prototype, so it's very similar. And in the control intervention, we're seeing a baseline of 21.7 and an endpoint score of 22.6. So it's actually, minimally different or just a little bit worse. Again, very consistent with what we've seen in our prototype intervention. So we're very encouraged that once we collect our full sample, it'll continue to go positively. So if we think about that, how should epilepsy self-management be implemented? Data, including our own, is suggesting that treating mental symptoms in epilepsy could improve outcomes. It may potentially reduce mortality risk from SUDEP and suicide. Now, in our little samples, we don't have data to say for sure we can reduce mortality, but we believe that if we can reduce depression significantly, both clinically, statistically, we should be able to reduce some of those other complications. Our CASE team, CWRU team, has received a new 5-year grant from the CDC to adapt time so that it can be administered remotely. So one of the things that we learned about time is that people with epilepsy really have a hard time coming to 12 sessions in a row every week. They have to take buses, they have to rely on others often for transportation, and it's just very hard. We are allowing telephone participation in time. That's been very helpful for us, but we'd like to expand that and make the intervention totally web or telephone based. Then we will also engage additional high-risk group in our new grant. We have co-investigators from our county hospital at Metro and also co-investigators from the VA hospital, so we hope to broaden our enrollment expanse. And then we'd like to see self-management embedded in both community and in healthcare settings. So our intervention definitely doesn't have to happen in a clinic or a doctor's office. It can really anywhere. And one way to sort of think about this is this is a graphic that I adapted from the Institute of Medicine, talking about health promotion approaches for people with a variety of chronic conditions, but here we'll focus on brain disorders like epilepsy. So you think about health promotion approaches. So the sort of easiest or top tier would be universal HPAs. And that would involve anybody who has a condition, so all patients or all individuals. It's minimally intensive, it could be easily disseminated, it's cheap. So an example that the Mu Network has developed is an entirely web-based program called WebEase. Now you do have to have a little bit of sort of computer skills to be involved in that, but for many people in the population that might work just fine. Then you have a second tier, selected HPAs, and here you target these people who are at risk for poorly controlled epilepsy or for depression, and you might be able to identify this on demographic or clinical variables. So for instance, many healthcare systems now have electronic health records, and you can very easily identify subgroups or cohorts of individuals that have the health conditions of interest. So for example, those kinds of, that second tier, an intervention like our SMART intervention, our new intervention where you're delivering it via web or telephone might be a good use of your healthcare dollars. And then lastly, indicated health promotion approaches target those known to be at very high risk, more serious depression, more poorly controlled epilepsy. This is highly tailored and of greater intensity. And then our time intervention, I think, is a good example of that. So, thinking about all the terrible stuff that can happen with epilepsy, maybe it's worth it to have a cab service or a shuttle service pick people up and bring them to those 12 sessions. And that might be, boy, that would pay for one emergency room visit. You're done. Where would we rather spend our healthcare dollars? One emergency room visit or something that helps somebody going forward? Okay, so in conclusion, we know that mental disorders worsen outcomes in epilepsy. Epilepsy self-management can improve depression and has the potential to ultimately reduce premature mortality, possibly via the person having fewer seizures and less depression. Future challenges include targeting the self-management to the specific person, So who should get what type of intervention? We believe it's important to address other types of comorbidity. So we've really only looked at mental illness here, but people with epilepsy have a lot of other comorbidities that should be addressed. Actually, we have a grant in now that's sitting under review soon that we hope to be able to look at some other comorbidities. And then the practicality of making self-management widely available to people with epilepsy who have transportation and other challenges. So we hope to be able to address that in our new SMART study. And I'm hoping I did a good enough job that I can get invited back in a couple of years to share our SMART study results with you. So I think that's all my slides. But I have time for questions, right? A few minutes?
Absolutely. Yeah. Absolutely.
So thank you.
Anybody have any questions? I'm going to write down a few. How many, so it's a weekly session and 12 of them.
Yes.
How many of the folks that were enrolled completed all 12, or you didn't really, or maybe comments on sort of attendance and completion?
So for people that attend, we actually have reasonable attendance. So we have, there's always some people who have difficulty getting out at all. We do have ways of addressing that. People can do makeup sessions. So let's say you missed a session, but you're coming for the next session. We might ask you to come a little early and make up that material. It's not the same, but we believe it's better than nothing. And then the other thing that we've started doing with time is letting people call in. And that's worked out very well. We put them on speakerphone. I believe that their participation is pretty close to what it would be being there. So for individuals who show up, the attendance is not bad. I don't have all my numbers, so I can give you a percent involvement, but we will have that because we do take attendance. Any other? Yes?
It was your slide early on. You talked about providing a conducive social environment for people with epilepsy. What would that look like? Could you repeat the question?
Yeah, so the question is how can you provide a conducive social environment for people with epilepsy? So that really is an excellent question, and I can answer it on several levels. So for instance, being in our groups is a highly supportive and beneficial social environment. Many people who are in our group tell us that they have never been in a group where somebody is in the group who has epilepsy who has also struggled with a mental illness. And because of that double stigmatizing nature, I mean, that's just huge to be able to do that. So they're in that during the course of the group. During the course of the curriculum completion, we do focus on what people can do to broaden and make their social environment more supportive. So are there other organizations that they can be involved in? It'll differ for the person depending on their resources, what part of town they live in, whether they have access to transportation or not. Things like websites that can be important. For example, I mean, people may not have all that information to allow them to do that. Now, what I'd like to see for the future is some additional online communities. We don't have that in our current model, but I think that's where I'd like to see it going. So once people are done with the programs, how can they continue to make contact? Now, we had a similar project that we did that didn't involve people with epilepsy, but it did involve people who have depression and comorbid Parkinson's disease, which is another type of neurological condition. And after that program was done, one of our group participants had a party at his house and invited everybody in his group. So, I believe that those kinds of positive social interactions is like a really good nidus that we can move forward. I don't think this solves all the social problems, but I think it's an important step. Yes?
Are you tracking if people are staying in touch with if the participants are staying in touch after?
So that's a good question. The question is, do we track people's additional communication with the other? We do not. We did not put it in our current grant. And part of the trickiness is we would have to get IRB approval to continue to follow people, which can be a little complicated. So we haven't done that yet. But going forward, I think that's another thing to do is, how can we actually track people's sort of social networks? And there's a whole field about kind of social networks that I think will be the next steps. Yes?
How many participants were in each session?
So in this cohort, it's 6 to 8 is what we're targeting. Originally, we were going to do up to 11 in each group, but very quickly, like almost immediately decided, and this is where we changed our study based on kind of the practical input from our people, is because there was a lot of content, and because people were hearing some of this for the very first time, and because some of our people did have cognitive difficulties, we went from going to do 2 cohorts to doing 3 with smaller groups. I have done groups as big as 10, but I think the ideal is 6 to 8. I think once you start to get beyond 8 people in your group, because you have 8 people plus your peer educator plus your nurse educator, so you've got 10 people in the room, and I think once you start to get beyond that, it's hard to have a good interactive discussion. So that's what we recommend at this point. Any other questions or comments? Yes?
What is the prevalence by gender? Does it differ? Do more women have these issues together, or more men, or?
Well, it depends on the health condition. So epilepsy will differ depending on the types of epilepsy. You know, you can have epilepsy from head trauma. You can have epilepsy that, you know, just starts when you're a kid and people don't really know why. In terms of the mental disorders, there are different gender patterns. So for instance, depression is much more common in women. But bipolar disorder and schizophrenia have an equal gender proportion. So depending on the type of mental condition you may or may not have. Now again, here I think we were affected in our gender distribution by the type of approach that we're using. What we have seen in all of our projects, except for the one with Parkinson's, is that when you say, you know, I'd like you to come to a group, women are just, you know, sign me up. And we have a hard time getting our men sort of stepping up to the plate for that. So it may be that, you know, what I've heard from some of the other investigators who are doing this type of thing is that with the web-based intervention, engaging young men tends to be easier. So we're hopeful that may be as we go to a different type of intervention. We'll see. Other questions? Yes.
I'm thinking about the fact that so many epileptics are unemployable. Is that, would you say that's
So first of all, I would say they're not unemployable. However, employment is difficult for many people because of some of the logistics. So if you're not driving, and you've got an employer that may not be amenable to, you know, your use of public transportation, that may be a huge barrier. There's also the issue of, you know, if a person is on disability, you know, when we have some of our people who have both the epilepsy and the mental illness, when you're on disability, you actually, there's a disincentive to work because you'll lose your disability. So the way our entitlements program is set up, it's not really incentivizing working. And so that's another problem. So I think employment is a really tricky issue. Unfortunately, there still is discrimination. So employers are not supposed to discriminate based on health status or disability. And I think mostly they don't overtly, but it can still be very difficult. And if you talk with people who have epilepsy, either with or without mental illness, they will tell you many, 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 many stories about discrimination. So unfortunately, it's very much alive and well.
Do you think or have any idea how that might play a role in the depression?
Yes. So stigma is depressing. Stigma is really depressing. I mean, it's really nasty. When you hear the stories, it's just really nasty. And people feel bad about themselves. And with stigma, what you get something is something called external stigma and something called internal stigma, you know. And if you hear criticism long enough and early enough, you start to believe it. I mean, if somebody tells you you're stupid often enough and early enough, especially when you're a kid, you start to believe it. And so then you have this internalized or self-stigma as well. I know, I keep coming off. I'm doing the best I can. So yes, stigma absolutely worsens depression. But I think we have to be careful about not stigmatizing the stigmatized person either. And that's why I talked about this bidirectional relationship between epilepsy and depression. So it's not that, oh, you have epilepsy and so of course you're going to be depressed. But there are neurological processes that we know are going on where these two are biologically linked. So it is interesting. And depression is a medical condition just like diabetes, just like hypertension. We know that it's treatable. There's things that you can do. And that's part of why it's so important to reach out to get people engaged. Many individuals in our time groups have not been involved in any kind of effort where they focused on both health conditions at once, and they can talk about it. So it's not only a safe environment, but it's a supportive environment. All right, I think I've talked your ears off, so let me stop there, and I want to thank you very much for your time and your effort.
And you certainly are welcome back. We'd love to hear about the next trial and the next phases. And
so while I don't know if I'm still on recording, but I'm also going to take this moment to shamelessly plug, we are enrolling both for our time and our SMART studies at this point, and I have two wonderful assistants, Jamie and Carrie, here. So if you would like to hear more about our projects, be involved in some of our community advisory boards, know